Thank you, and I'd like to thank you for inviting me to this conference with such a spectacular list of speakers. I'm really astounded with the quality of the people that you've brought here for this, and I'm honored to be one of them. My job today is to help you understand that the rapid response system is a system, how it works and why it works. I will be just touching on some things that will be delved into much greater depth by all the rest of the speakers today. And my job is to try to teach you in 30 minutes what took me 10 years to learn. And so we'll see how that goes. So I want to start off with talking about how hospitals work and what our origin is. This is Florence Nightingale, who had the brilliant insight that we should cluster patients near where the resources are. She was able to reduce the death rate during the Crimean War by some 60% just by moving the patients around, and so they would put the sickest patients nearest the nursing stations. She created nursing stations. She created collecting vital signs at regular intervals, including, amazingly, during the night. And so a lot of people think William Osler is the father of modern medicine. I really believe it's her, because we're still doing exactly now what she did well over 150 years ago. William Osler was also a great leader, and he designed the hospitals the way we know it now, where you have tiered educational levels and doctors rounding through the hospitals to see those patients. And this is a system that has worked very well for a long time, well over 100 years. And the system works as long as the resources and the needs are matched. That's why Florence Nightingale was able to reduce the death rate. She moved the people who needed the most resources nearest to where the resources were. And so this works fine. If the resources are equal to needs, that's happy. If the resources are greater than the needs, that works for the patient, but it's wasteful. And if it's less than the needs, it can be a problem. And it can become a crisis. When the patients are in crisis, it could be life-threatening. Because you have two choices, either to move the resources to the patients or move the patients to the resources. And the old way was you just move patients around in the hospital. The problem is people don't always have that amount of time to live before they have to have those resources. And me learning this just required looking. I remember my boss telling me that my job as head of the code team was to make sure that codes never happen. And I said, you can't do that, that's impossible. And we had this argument going on for a while, and he challenged me to look at charts, and after I had looked at 4 charts, I knew he was right, that there was dysfunction within the hospital. The hospital itself was sick because we were adhering to standards from the 1800s here in the 2000s, or at that time it was in the 1990s. And we found that over 2/3 of patients who had a cardiac arrest in hospital had warning signs that if had been attended to appropriately, that patients would have survived. So I worked on this for a while, and when I finally finished my first paper, I was reminded kindly in the review that I should be looking at the people in Australia, so naturally I called them up right away, and I developed what wound up being a career-long friendship with Kenneth Hillman and Ronaldo Balomo, who just recently died, and myself. We met in Brussels at one of Jean-Louis' conferences and compared notes, and we realized that we were onto something big, and we needed to have a meeting to talk about our various response systems. Okay, they called theirs a MET, we called ours a condition C, but we had this team that went out to rescue patients, and we were really focused on team. When we got together to talk about what's happening, we spent most of our consensus conference talking about who should be on the team and how should they know when to go. And it wasn't until literally the last hour of the conference that we realized that the team was only one small part of what we had been doing for all that time, and we had all learned the hard way that if you don't have all 4 components, you're not going to succeed. And those components are the efferent limb or the action limb, the afferent limb or the area that that detects and recognizes and triggers a response. And then importantly, a quality improvement limb where you're counting what's happening, and an administrative limb, which provides basically the food and nourishment that the system needs. Gary Smith put this together in a very nice way in a chain of prevention, where there's education, you teach the hospital and the responders, there's monitoring, you detect something happening, and you recognize that this is a problem that needs different action than business as usual, and then you send out the team to respond. And to put the four components on that list, you can see that the education would be the responsibility of the administrative limb, the monitoring, recognition, and triggering, that's the afferent limb, and then the efferent limb is the responders. The quality limb oversees all of these. Are we educating well? Are we detecting well? Are we triggering well? And the administrative limb, which provides all the resources that are necessary for this. And you can see that we had been focused on just that little yellow arrow over there, and we missed until we got together and compared notes with a number of other people who were in the field, that this was an entire system. And we had failed for almost 10 years, I think. Jack might know how long it took them. I know Ken was 18 years working on this. I was 10 years before we realized that you needed to put all those pieces together. Now, this is a system that's also a system of systems. This notion of detection, response, quality to oversight, and then administrative support can be applied to any number of critical problems that occur in the hospital. For example, strokes, pulmonary embolism, and there are now papers in all of these fields regarding how do you best respond to prevent a death. Lost patient, I haven't seen duplicated elsewhere, but we had a patient at our hospital that died because we couldn't find her, and it was 20 degrees out, not too different from it is here, and she had found her way outside and froze to death. And it's a horrible story. And so figuring out how to prevent that from ever happening again was something that required us to approach it as part of our rapid response system. And so types of events and locations of event all need to be included in this system. So as I mentioned, the efferent limb was the most obvious. Let's just get the help to where it needs to go. And the key to that is rapid deployment of personnel and equipment. Both have to show up. If either one doesn't show up, they're going to be useless. And then there needs to be training of the people who respond so that they are nice when they get there and don't push important people out of the way. And we needed to train the hospital to know what the system is and how to call. So we embarked on this efferent limb education and staffing and resources, and eventually we got better. And it matters that people are trained. If people aren't trained, in the beginning when we first started this, we would get response, we like this when you go there, Dr. DeVita, but we don't like it when Dr. Smith goes there. And we found out that we had different ways of showing up. The catchphrase that we ultimately learned was, thank you for calling, how can we help? And which is a very different thing from saying, why did you call? Why did you call sounds like a challenge, but thank you for calling, how can we help? People will tell you what it is they want. So we had to train everybody. The afferent limb, and I think most of the day today is going to be dedicated to this, so I don't want to spend too much time on it other than to point out its place in the system. This is responsible for detection, recognition, and triggering. How we monitor is important. Florence Nightingale monitored in one way, and I think nowadays we are often monitoring exactly the same way, where we're doing vital signs based on the clock by hand, rather than having them done continuously on a variety of different organ systems. At our second consensus conference, we studied the afferent limb. We came up with 7 characteristics. Of them are they manual, automated, and you can read down the list. And I think the focus of this one is simple systems where you're just showing data, and smart systems, which actually analyze the data and either tell you what the risk is or provide you with the next steps of what you need to do. And there are hybrids of these, and I'm sure we are, although this field has been developing for over 10 years, I'm sure we're just on the forefront of what can be done with better monitoring and analysis tools. I've been long time an advocate for continuous monitoring of all patients in hospital. If you're sick enough to be in hospital, you're sick enough that we should know whether you're alive or dead in between those 4-hour or 8-hour checks that we do with the nursing staff. This is a graphic on the left side made by Ashish Khanna. And you see the same patient on 2 different units. One is continuously monitored and the other is not. Generously, the one on the left is monitored every 2 hours. So we find out that something bad has happened after the patient has already been in trouble for well over an hour. If there's continuous monitoring, we find this out very quickly. And so it is really important to recognize that the system that Florence Nightingale used in the 1860s is not okay anymore. We don't want people to die because we didn't check them at the time when they had a deterioration. They're not deteriorating at a time convenient for us. We have to be available to them all the time. And I think that we want to be able to detect those problems occurring as it happens. And I think this is the most important gap in healthcare, at least in hospitals, is we don't know whether the majority of the patients in the hospital are alive. If I went to any nursing unit and said, is this person alive? They would have to walk down to the room and look in it, unless they were already on a continuous monitor where you can see. There are simple ways of helping people recognize that something that's detected is important enough to call a rapid response. So there's detection, and then there's recognition. This is, Jack helped build this. This is the vital sign sheet that's in use in much of Australia. And they just put simple, it probably should be green, but it's white is normal, yellow is you're a little sick, and red means you need to act now. And there were specific requirements for duty that the different people working in the hospital as they were recording could do so that they knew we need to do something now. This improves recognition, which in turn improves triggering. So we're at a turning point, I think, in the afferent limb. Originally, this was just detect when people are deteriorating. I think we're trying to move forward so that we're detecting when they are going to deteriorate before deterioration becomes a significant thing. So we're trying to predict future deterioration. And this is what the eCart and the other systems, the Rothman Index and so on, are trying to do. This is a great example. This is very old, and this is a Biosign Index, BSI, and the higher you are, the more sick the person is in terms of the likelihood of them having a cardiac arrest. And I wanted you to look at a couple of things. One is the baseline here is inching up as it goes along. So it's a baseline change that it's very difficult for staff to see. Then there's a frequency of deterioration, which also increases as the patient gets sicker. And then there's an amplitude that changes. Most of these changes are about like this. Towards the end, they are all large. And if you can analyze that signal, you should be able to pick up that this person is in trouble down here 6 or 7 hours before. And as we get better and better with things like adding in labs and underlying disease and age, we are getting very, very good. And so the hope is that we never get to the point where you have these different opportunities to call an RRT here, and this is where it was finally called. We could start work here and prevent all the rest of this cascade from happening. And I think I'm very optimistic about this future. The problem with predictive models is they predict. They're based upon what's happened in the past. They are not very good at predicting something. So this is also an old slide where Gary Smith looked at the area under the receiver operating curve was about 0.78 or so, which at the time was very, very good. Now, with the systems that you're going to be hearing about later on today, the area under the curve is well over 0.9, and they've really become fantastic. So we can capture the vast majority of people who are going to get into serious trouble in the near future. The problem is as long as it's not one, there's people that the predictive model is going to miss. And I think the things that they're going to miss is the random events. me getting your medicine, me having a previously undocumented allergy, somebody gets sent to the wrong place at the wrong time, somebody who, people in the MRI scanner who start having a slow deterioration and then they deteriorate suddenly, we might be able to predict it, but they're in a place where we can't get to them very quickly. So the whole idea is to be able to detect those problems as well. And I think these work hand in glove. You never want the detection system to ever run. You need a good predictive system to do that. But if it does happen, you want to be able to respond to it quickly. And the only way is with having continuous monitoring. And I think, as I mentioned, I think we're at the very forefront of AI and becoming really, really very good at not only figuring out when to respond, but what to do when you get there. The quality limb is the scorekeeper. I think the thing that helped all of us was recognizing what we were doing wrong. This was one of those things that once you see it, you can't unsee it. Once I recognized that there was a problem with the way we do business routinely is very dangerous when you're sick. If you're not sick, everything's great. There's no problems there. But when you become sick, the routine we have can be very dangerous. The beauty of a rapid response system is that there are rapid response teams going out. They should be going out something like 60 times more frequently than a cardiac arrest team. So you can collect a lot of events very quickly, and you can start finding out things that go wrong. The problem is when you have a lot of events, there's a lot of work, and that can compromise staffing elsewhere. But when you have a lot of events to analyze, you can pick up things that are very subtle. For example, we learned that the most common cause of death from hyperkalemia was hypoglycemia. People were treating hyperkalemia with insulin, and they would die 2 hours later from hypoglycemia. And so that was just one of many problems that we discovered. And it was because we had so many things to look at that we could look for commonalities that weren't obvious if you didn't have a sample size of thousands of patients a year. This is a recent paper that came out, not too old, where they looked at practices associated with good survival from in-house cardiac arrest. And the most interesting point to me was that just having a quality, just reviewing the cases was more powerful than either monitoring for interruptions or having a champion in hospital. This was the most important determinant, was looking at what you're doing. Counting is very important. And administration, of course, is important. Their role is a number of things. They need to provide money. They need to be broadcasting to people so that everybody knows what we're trying to do and why we're trying to do it and how we're going to do it. They need to be cheerleaders. My boss was a fantastic cheerleader. Whenever somebody tried to quash a rapid response, and some nurse who didn't know better would call us and let us know, he would send a thank you note to the doctor for saying, thank you for calling the rapid response, you saved your patient's life, even though the doctor had tried to block it. And it turned out to be a very effective way of getting people to buy in. And then the need for them to create a sense of urgency, pants on fire. And these are all strategic things that the administration does. So you won't see their fingerprints on any particular thing, but they're the ones who create the milieu in which this can develop. Changing culture is really hard in hospitals, and it is particularly hard when you're trying to get doctors who think they can do everything realize they need help before they realize they need help. And so developing things like mnemonics, training systems, we had end-arounds, so we would, new nurses to the hospital, we would orient them, when this happens, this is what you do. And so they would know what they're supposed to do before they learn from the culture that you shouldn't do that. And so we would get a lot of responses that way. So what I've learned, the two most shameful secrets in healthcare are our patients alive? I think if you don't have 100% monitoring, continuous monitoring in the hospital, you cannot answer that question honestly. You can think you're probably right, but you don't know for sure. And then this isn't the purpose of this talk, but I always put it in here. Most hospitals, and I've given this talk all around the world, when I ask the audience to say one word that describes your cardiac arrest response, everybody says chaos. And it takes a lot of training to make it not chaos. So I think these are, if this was on the front page of the newspaper, we'd all be embarrassed. The weakest link, I think, is our ability to know whether our patients need our help or not. And that's why this conference is so important. We are going to learn today about how to do this in a way that's better than we did it yesterday. This is a very powerful intervention. In the United States alone, this has been estimated to save 100,000 lives per year, and internationally, 1 million lives per year. It's astounding. At our hospital, we decreased our cardiac arrest rate by 2/3 and saved 250 lives per year. We have to recognize that while hospitals are really good, they're sick. There are ways that we can improve them that are fixable, that are going to require initiatives like this one to make them a safer place. And I saved this for last. Australia, New Zealand. This is a paper recently by Daryl and Jack and others. They're at 0.27 cardiac arrests per 1,000 admissions. As a reference point, when we started at the University of Pittsburgh, we were at 8 per 1,000. They started at 7 per 1,000, and we've been whittling it down. The best we ever got at University of Pittsburgh was 2 per 1,000. They're 10 times better. And it's because they've attended to every last little detail in getting it right. Everybody knows this is the way the whole country does it, and I think we all want to be as good as they are. Jack will tell you more about that later, I'm sure. So where do we go to from here? 100% of patients continuously monitored, required reporting, mandatory annual training, valuing family calls, and of course, I think better these surveillance systems that employ AI to help predict as early as possible when a patient might be deteriorating. The goal is 0. I gave a talk at the Royal College of Physicians where I had one slide and it was a 0. And I talked about how are we going to get to 0, and I'll tell you, I got shouted down. It was not a pleasant experience because it is impossible, so they said. And I agree, it probably is impossible to prevent all of them, but this should be our target. We're still trying to get there. And we mentioned the International Society for Rapid Response Systems. There is a website. Joining it is very inexpensive. There's all kinds of educational materials on it. Everything you hear today is somewhere embedded on that website, and I encourage you all to join. Thank you very much.